Hello everybody, welcome to this month's ERA Journal Club. I'm delighted to see so many of you being able to join, and we have a fantastic panel today that's joining me. So each month the ERA's e-seminar usually takes place, as you're aware, on a Thursday, but for this month it's shifted to today, a Monday at 1700 Central Eastern Time, which is 4 p.m. Oxford UK time, which is where I'm based today. This month we're delighted to have Professor Richard Haynes, who is a professor of renal medicine and clinical trials, and you'll be aware the co-PI of the Kidney trial, who will be moderating the session with me, as opposed to the usual familiar face of Professor Will Harrington, as he's away on leave. So I'm delighted that that Richard's able to support me. We're both Oxford-based nephrologists, clinical trialists, and also work in kidney epidemiology as well. So as you're aware, each month the e-seminar has picked out a topic from an original research or key article that's published either in NDT or CKJ, and the author or the authors usually come along to the e-seminar and present their work, and we always have at least one expert panel member as well that's external to the team. So the discussion will be focused, it will be fairly informal, and we like to encourage as much live and hopefully lively debate and questions from you all. For you as yourselves, as the audience, please do type them into the chat box in the Zoom Q&A box, and we'll, myself and Richard will be reviewing that and keeping an eye on those, and we'll feed them back to the presenters at the end. As you heard at the start, the video is recorded and it will be made available on various video platforms following the talk. So do please keep an eye out on social media for the links. So for today's topic, as you can see, we'll be covering endothelin A receptor antagonism, which have previously been shown to reduce albuminuria, but were also associated with sodium and fluid retention, and as a result, an increased risk of hospitalization for heart failure, particularly in people with diabetes and kidney disease. However, now with the introduction of SGLT2 inhibitors as part of the standard of care for patients with chronic kidney disease, we feel that there is a potential mitigation or mitigating strategy that might be able to be combined with endothelin receptor antagonists to try and reduce that risk of heart failure and fluid retention, as well as further enhancing the albuminuria reductions that have previously been shown with this class of agents. And today we'll hear about the ZENITH-CKD trial, which is one such trial testing a combination of dapagliflozin, an SGLT2 inhibitor, with zibotentan, an endothelin A receptor antagonist. And so I'm very delighted to be able to introduce to you the first author of the trial paper, Professor Heerspink. So Professor Heerspink is a professor of clinical trials and personalized medicine and a clinical trialist at the Department of Clinical Pharmacy and Pharmacology at the University Medical Centre of Groningen, and a visiting professor at the University of New South Wales in Sydney. As many of you will be aware, he's led numerous clinical trials and interventions to reduce kidney and cardiovascular complications of chronic kidney disease. So the paper that we'll hear about shortly was published online in NDT in August, and I'd like to take the opportunity to thank you, Professor Heerspink, for bringing your work to NDT and also to this ERA Journal Club. I'd also like to take the opportunity to thank and introduce Professor Neeraj Dhaun, who is a professor of nephrology in the Centre of Cardiovascular Science at the University of Edinburgh. His research focuses on cardiovascular risk associated with CKD, and he's extensively studied the role of endothelin in cardiovascular and kidney disease and hypertension, as well as the effects of endothelin antagonism. So we have a broad range of panelists that will be able to share their knowledge and insights. So I'd like to thank you again for joining us. So we have a stimulating topic and a world-leading expert panel, a live presentation and discussion. So please do take full advantage and submit your questions into the Q&A of the Zoom platform. Please don't be shy. So without further ado, Professor Heerspink, please do share your screen, and I welcome you to start your presentation. Thank you.
Thank you very much for giving us the opportunity, and in particular me, the opportunity to present the design and the rationale for the ZENITH-CKD trial, a clinical phase 2b trial in patients with chronic kidney disease that indeed will look at the combined efficacy and safety of an SGLT2 inhibitor with an endothelin receptor antagonist. My disclosures are listed here. So we've seen in the last couple of years that after many years of stagnation, after the introduction of the ACE inhibitors and angiotensin receptor blockers, that finally we have new therapies for our patients with chronic kidney disease. And actually it all started with the endothelin receptor antagonists that were just presented before the Credence trial in 2019 at the World Congress Nephrology in Melbourne. And that clinical trial demonstrated that an endothelin receptor antagonist in patients with diabetic kidney disease significantly reduced the risk of kidney failure or a halving of kidney function. And then at that same meeting, directly following the presentation of the SONA trial, the Credence trial was presented and demonstrated, as you know, that dapagliflozin, the SGLT2 inhibitor, was also very effective in not only reducing the risk of kidney failure and the doubling of creatinine, but also heart failure. Following these two clinical trials, two other trials have demonstrated the benefit of the SGLT2 inhibitor class, dapagliflozin, and last year we heard the results from the EMPA-Kidney trial, and we have another new drug that is effective in slowing the progression of chronic kidney disease, namely a non-steroidal mineralocorticoid receptor antagonist, finerenone, as demonstrated in the Fidelio-DKD trial. And only about 10 days ago, we heard that another drug is very effective, likely, in slowing progression of diabetic kidney disease, namely semaglutide, another trial that was stopped early for overwhelming or clear efficacy. Now, focusing on the SGLT2 inhibitors, as I just mentioned, 3 dedicated outcome trials demonstrating very clearly that these SGLT2 inhibitors are effective. And some people believe that we have solved the issue of diabetic kidney disease and that we have eradicated diabetic kidney disease because these SGLT2 inhibitors are so efficacious. And of course, these drugs are very effective in slowing the progression of kidney disease. But equally, we have to acknowledge that if we look in the dapagliflozin or dapagliflozin or empagliflozin treatment arms, there are still patients who progress towards kidney failure or a doubling of creatinine. And thus, we should consider additional therapies, in particular in the patients at risk of progression, those with high albuminuria or a low GFR. So what other therapies do we have? Well, I believe that the endothelin system is a very important system involved in the pathophysiology of chronic kidney disease, and targeting endothelin-1 can slow progression of kidney disease. As so nicely illustrated and reviewed in a paper in 2014, endothelin-1 is implicated in the progression of kidney disease. Endothelin-1 by itself can be released in the setting of hypoxia, when there are a lot of growth factors or by inflammatory cytokines, or even when there is aging or activation of the renin-angiotensin system. As soon as endothelin-1 binds to its receptor, the endothelin A receptor, there are a lot of additional pathways activated that cause the progression of chronic kidney disease and tissue damage. In the vasculature, activation of the endothelin A receptor causes vasoconstriction, endothelial injury. At the level of the podocyte, it causes nephrin shedding and proteinuria. In the renal tubule, activation of the ETA receptor causes tubulointerstitial fibrosis. And there's even mesangial proliferation, matrix accumulation, and inflammatory cell infiltration and inflammation. So all these effects together can lead to a progressive kidney function loss. And so blocking the endothelin A receptor in the kidney could protect against that progression. That endothelin-1 is implicated in the progression of kidney disease is nicely illustrated by knocking out the receptor. On the left, we see that in diabetic animals, wild-type diabetic animals, And there's a consistent increase in glomerular sclerosis, as you can see in the second cartoon on the left and in the bar graph where the glomerular sclerosis is quantified. Now, if we knock out the endothelin-1 receptor, or if we knock out the endothelin-1 itself, you can see that there is no difference between the control and diabetes animals in terms of glomerular sclerosis, as also quantified here in the graph at the bottom left. Endothelin-1 is also implicated in the glycocalyx. The glycocalyx is a gel-like structure that covers the endothelium. The glycocalyx is negatively charged, and in healthy conditions, albumin, which is also negatively charged, is repelled from the endothelium, and thereby the leakage of preventing leakage of albumin across the glomerular basement membrane. Now, in a diabetic state, heparinase, which is an enzyme that cleaves the glycocalyx, is activated, and as a result, we see a reduction in the glycocalyx thickness, and that's illustrated here in the graph on the bottom right. In diabetic animals, we see a reduction in glycocalyx, which can also be seen here in the cartoon. Now, in knockout animals for endothelin, you see there's no more reduction in the glycocalyx thickness, and thus, if you block the endothelin system, you can probably prevent the reduction in glycocalyx thickness and thereby reduce albumin filtration. And indeed, clinical trials have demonstrated that endothelin receptor antagonists reduce albuminuria. This is one of the earlier studies published in 2009 that shows that a high dose of a relatively unselective ATA antagonist, afoxantin, in people with type 2 diabetes and a GFR above 60 significantly reduces albuminuria. And based on this study, a phase 3 clinical trial was conducted in people with a very low GFR. On average, that GFR was 35, and they all had very high levels of albuminuria. In that clinical trial, again, high-dose afoxantin significantly reduced albuminuria. But the trial was unfortunately stopped already after 6 months because of fluid overload, as can be seen here in the middle, that led to significant heart failure and mortality. And so the Data Safety Monitoring Board decided to recommend early discontinuation of the trial because of too many side effects. Based on this clinical trial, another clinical trial was conducted, but slightly different. And this was a clinical trial with the endothelin receptor antagonist atrasentan. Atrasentan, just like afoxantin, significantly reduced albuminuria in this study. The difference with afoxantin was that atrasentan was tested at a very low dose, only 0.75 milligram per day. And that's the squares in this graph. Because a low dose of an endothelin receptor antagonist can already reduce albuminuria. However, despite the use of this very low dose of atrasentan, there was still an increase in body weight, suggesting that there may still be fluid retention that causes the increase in body weight. So the phase 3 clinical trial that was following this phase 2b study carefully selected patients. So they selected patients who did not have heart failure. All patients were recommended to be using a diuretic. Patients with a BNP level above 200 picogram per ml were excluded. And in addition, the clinical trial used an active run-in period of for 6 weeks, where patients who could not tolerate the drug could not continue to the randomization visit, again, to avoid the risk of fluid retention or to minimize the risk of fluid retention and heart failure. And this was the result. In all patients who were randomized, the risk reduction for kidney outcome, kidney failure, or a doubling of serum creatinine was 28% relative risk reduction, statistically significant. But unfortunately, despite the precautionary measures, there was still a modest increase in the risk of heart failure hospitalization, as can be seen on the right. If we now compare this result with atrasentan, after 6 months, the event rate with atrasentan was 15%, which was much higher than what was observed in atrasentan, around 1 or 2%. And this reflects the population, likely reflects the population that was included in the SONA trial, namely a population that was at intrinsic low risk of heart failure, but still there was slightly more heart failure with atrasentan. Now, when these trials were published, we started to think whether we could not combine atrasentan or an endothelin receptor antagonist together with the SGLT2 inhibitor, because we know that SGLT2 inhibitors exert diuretic effects. And this is illustrated here. At the top, we see the endothelin receptor antagonist, which show kidney protective mechanisms. They lower blood pressure, they lower albuminuria, and they may also lower inflammation and fibrotic pathways. But they have a safety concern, namely they cause volume retention, possibly leading to heart failure. Now, on the other hand, we have the SGLT2 inhibitors. They lower blood pressure, lower albuminuria, lower inflammation, but they lower volume retention, possibly a modest reduction in BNP. So could it be that we combine the two drugs to augment kidney protection, but at the same time mitigate the volume retention which is induced by the endothelin receptor antagonist by adding an SGLT2 inhibitor? So we started to test this hypothesis in animal studies. And we used the most selective endothelin receptor antagonist, zibotentan. Zibotentan is produced by the company AstraZeneca, and we did an animal study. And the animal study was published earlier this year, I believe in June, in Nephrology Dialysis Transplantation. And we first used zibotentan alone to test whether zibotentan causes fluid retention in this animal model. And we used 3 different doses of zibotentan, 30, 100, and 300 milligram per kilogram body weight of these animals. And the results are shown here. Hematocrit significantly reduces after 7 and 14 days treatment with high doses of zibotentan compared to baseline. And indeed, we also saw increases in body weight. So this reduction in hematocrit suggests that there is increased fluid, suggesting fluid retention, which is accompanied by an increase in body weight. So in this model, we can induce fluid retention alone with zibotentan. And then on the right, we started to combine zibotentan with dapagliflozin. And we measured hematocrit. So dapagliflozin, shown here, with zibotentan causes no difference at low doses of zibotentan. But at the higher dose of zibotentan, you see that together with dapagliflozin, the zibotentan reduces hematocrit compared to no treatment. But then with dapagliflozin, we see an increase in the hematocrit level, suggesting that indeed you can mitigate part of the fluid retention by adding dapagliflozin. And that's also illustrated if we look at the body weight changes. Now, at the same time, directly after we conducted and completed these animal studies, we started a clinical study. And before we started the clinical study, we also did a post-hoc analysis of the SONA trial. I mentioned that in the SONA trial, there was a 6 weeks active run-in period to assess if patients could tolerate atrasentan. Against the protocol, there were 14 patients in the SONA trial who started at the same time when they started atrasentan, also an SGLT2 inhibitor. And normally you really don't like it, but in this case, it gave us the opportunity to match the 14 patients who started atrasentan in combination with an SGLT2 inhibitor to 42 patients with similar baseline characteristics who started atrasentan alone. And when we look at body weight, atrasentan alone causes a modest increase in body weight. But if we look at the combination atrasentan and SGLT2 inhibitors, we see a decrease in body weight. The similar pattern is seen for BNP, although not shown on the slide. Atrasentan alone causes a modest increase in BNP, and the BNP did not change with atrasentan and SGLT2 inhibitors, suggesting that we can mitigate some of the fluid retention induced by atrasentan. And then when we look at the efficacy signal, albuminuria reduction, we see a further reduction in albuminuria compared to atrasentan alone. However, these were only 14 patients who started combination, which is very small, and this study could be is prone to chance findings. And that's why we started a phase 2b trial to test zibotentan in a prospective clinical trial alone or with dapagliflozin. The trial consisted of two parts. Part A, where we test zibotentan alone at a relatively high dose, 5 milligram, compared to DAPA alone, compared to the combination, compared to placebo. However, this study lasted 12 weeks treatment followed by 2 weeks. But this part A of the study was already stopped prematurely after an analysis of the Data Safety Monitoring Board, who saw increased fluid retention at the 5 milligram dose and the 5 milligram and DAPA 10 milligram dose. In addition, because of evolving guidelines that recommended dapagliflozin for all patients with chronic kidney disease, we also stopped the placebo arm so that we, in phase B of the study, only test a low dose of zibotentan, 0.25 and 1.5 in addition to DAPA, compared to dapagliflozin plus placebo. And this study recruited 477 patients. We enrolled adult patients with chronic kidney disease with a GFR above 20 and a urinary albumin to creatinine ratio between 150 and 500. The main exclusion criteria are shown here. Patients with a BNP of greater than 200 picogram per mil or NT-proBNP of greater than 600 were excluded, as well as patients with heart failure, uncontrolled diabetes, or type 1 diabetes. As I mentioned, 477 patients were recruited and were available for analysis, and their mean age was 63 years. 31% was female. Majority were white, 68%. 58% of patients had a diagnosis of type 2 diabetes, so 42 did not have diabetes. Their mean GFR was 47 mils per minute. Their median albumin to creatinine ratio was 566, and nearly all participants were using an ACE inhibitor or ARB. So with that, I'm going to conclude that SGLT2 inhibitors and endothelin receptor antagonists are potent drugs to slow CKD progression. I showed you that the ZENITH trial was designed to assess the efficacy and safety of combined treatment with zibotentan and dapagliflozin and to find the optimal dose of zibotentan in combination with dapagliflozin. And as I mentioned, the results will be presented very soon, in about 10 days from today, at Kidney Week in Philadelphia. I thank you very much for your attention, and now I give the word back to our chairwoman.
Fantastic. Thank you very much, Professor Heerspink, for that riveting presentation. I'm sure that you've got a lot of people very excited for the phase 2 results in 10 days' time. So congratulations on the late-breaking clinical trials oral presentation. And thank you also to Professor Dhaun for answering some of the questions in the chat along the way. I can see that there's another question in the chat at the moment. Professor Haynes, would you like to address that to the group?
Yeah, so Gavin Chapman has asked a question about the necessity in the phase 2 trial, Hiddo, for patients to have albuminuria. Given what we know about the mechanism of, or what we think we know about the mechanism of endothelin antagonism on the kidney, do you think that albuminuria is a prerequisite for them to work, or do you think they could work in people with lower albuminuria? And B, you can think about that one as well. So give us your response when Hiddo's answered.
Yeah, we enrolled patients with high albuminuria in this study because albuminuria was our outcome, and that's a typical outcome in a phase 2b study. And if there's no albuminuria, it's very difficult to show a reduction in albuminuria. So for this study, we had to enroll patients with higher albuminuria levels. We do that also in phase 3 trials to enhance the risk of individuals for progression of kidney disease, because albuminuria is such a strong risk marker. We usually test patients at higher risk. Otherwise, we need very large clinical trials. And I know that in Oxford, they can do such trials, but they cannot be done by everyone around the world. So could it be that endothelin receptor antagonists are also efficacious in people with very low albuminuria levels given the mode of action? I would think so. Endothelin receptor antagonists, they reduce blood pressure. They have beneficial effects on glomerular hemodynamics. They reduce inflammation. And if a patient with high blood pressure and perhaps an inflammatory state in the kidney would be treated with an endothelin receptor antagonist, I would think that these drugs could also slow the progression of kidney disease. I am not aware of clinical trials that have tested that hypothesis specifically. I know that there are clinical trials that have tested the glomerular hemodynamics, and we have the expert here in the panel as well. But I think that in the long term, you would see a slowing of the progression of kidney disease. But as I said, Bean, I'm very interested in your ideas as well.
Thanks, Hiddo. Yeah, I mean, I agree with you. I mean, there are preclinical data showing that endothelin antagonists will improve a range of kidney diseases irrespective of underlying cause. And in those studies, they looked at histology, measured GFR, etc. In clinical trials, Hiddo is absolutely correct. I mean, the rationale for using proteinuric CKD, whether it be diabetic or non-diabetic, is patients will progress, are more likely to progress, but also with thinking of why drug companies would do these studies, they need something to go to the FDA with and say, here's a measure that you might consider acceptable for registration or temporary registration. There are clinical studies in treatment-resistant hypertension, where they've used endothelin antagonists, and in that setting, about 20 to 30% of patients have had microalbuminuria and modestly reduced GFR, and in that setting, the endothelin antagonist has reduced the proteinuria further and preserved GFR, and that was using a mixed antagonist called zibotentan in the Precision study. But yeah, there's no.
Important to note being that in that trial there was quite some fluid retention as well with that high dose aprocitentan, and that supports at least the idea that we have to be careful with these drugs, in particular in patients with chronic kidney disease. And in my view, there are different approaches how you can mitigate that. Go to a population at an intrinsic low risk of fluid retention, like IgA patients, or select patients, as we've tried to do in SONAR, by all kinds of inclusion and exclusion criteria. But that is also difficult, because you would like to have the drug available to a broader population in clinical practice, and not all these criteria. And then the third approach is to combine it with an SGLT2 inhibitor, and we'll see if that approach is useful in a couple of weeks, days.
Excellent. Thank you very much for that answer. Just following on from that, Professor Heerspink, one of the sort of pre-seminar questions that was sent to us was sort of really about what do we know about the safety and efficacy of zibotentan specifically, as compared to sort of other drugs in this class. So what are you able to tell us? Obviously limited information based on your phase 2 data at the moment, but what is it, a class effect, the fluid retention and heart failure, or are there sort of drug specific effects?
Yeah, the class, all the endothelin receptor antagonists will cause fluid retention, in particular if you give them in high doses. So the higher the dose, the more fluid retention you will see. That's a class effect. And so the challenge with the endothelin receptor antagonist is to find the right dose, low enough to still reduce albuminuria, but not too high, because then it causes fluid retention. And the interesting thing is that if you look at the endothelin receptor antagonist, the dose response curve for albuminuria reduction is different than the dose response curve for fluid retention. So that basically means that you can find the dose where you still have albuminuria reduction and thus likely protection and no fluid retention. And you have to find that optimal dose. And in that, if you are able to find that optimal dose, then you can test it in your population. Endothelin receptor antagonists, in particular the older ones, also have been associated with liver toxicity. What we now see with zibotentan is absolutely no signal for liver toxicity. And the same is true for atrasentan, that has been published a few months ago as well. So these drugs, although the old ones show liver toxicity, that's not a class effect. That is specific to, and that relates to the specific endothelin receptor antagonist. And then there are some other side effects which relate to, I believe, the fluid retention, like dilutional anemia that we often see. But that's not a true anemia, that's more a dilutional anemia.
And finally, do you think there's anything specific about the combination of an endothelin receptor antagonist with an SGLT2 inhibitor that might be superior to, for example, just adding an ETA with a diuretic? Do you think there's something additional that we might see from the combination that might mitigate some of the risk?
Yeah, I think so, because I think that an SGLT2 inhibitor is a very special diuretic, different than the traditional diuretics. SGLT2 inhibitors cause, in my view, osmotic diuresis much more than the traditional diuretics. So you don't see a direct effect on the potassium. In fact, with the SGLT2 inhibitor, we increase diuretic osmotic diuresis. And in doing so, we slightly, in particular in the first day or days after initiation, we slightly increase plasma osmolytes. And thereby we attract fluid from the interstitial phase directly into the plasma space in order, and thus you get a redistribution of fluids across the plasma volume and interstitial fluids. And thereby we reduce interstitial fluid and reduce the risk of heart failure. So it's that osmotic diuresis that is an important aspect from the SGLT2 inhibitors, which the traditional diuretics have much less. And that's why I think it's different with an SGLT2 inhibitor compared to a traditional diuretic.
Excellent. Thank you very much. Well, I'm sure that will leave the audience hanging in suspense as to what the results of the phase 2 study will or may be. So I think we're probably about at the end of our seminar and probably need to call time. So from all of the ERA Journal Club team, I'd like to give my huge thanks to you, Professor Heerspink, and to Professor Dhaun, and also my co-moderator, Professor Haynes. Apologies, he had to leave just before the end. Please do, to the audience, go out to the NDT website and read the paper. Obviously, even more reason to sort of familiarise yourself with it now, given the pending phase 2b pivotal results in, as you say, just in 10 days' time. Please do also go out to NDT and check out the some of the other work that Professor Heerspink mentioned in his presentation. So there is a animal-based study that was published in NDT back in April. This sodium glucose cotransporter 2 inhibitor dapagliflozin ameliorates the fluid-retaining effect of the endothelin A receptor antagonist zibotentan, which gave some useful insights and background into how the mechanism of these two drugs combined may help mitigate some of the risks that we're concerned about. So I just finally like to thank you again, and as always to the audience, please do go ahead and answer the survey within the Zoom link, which should appear shortly, and we appreciate your feedback to help keep these e-seminars running, and also to help us improve our future formats, or if you prefer any shorter formats or longer formats, or any of the changes, please do let us know. But for now, from me and all of the panel, it's goodbye, and thanks from all of the ERA team again for our speakers today. Thank you very much.